Welcome to The Explainer. Today we're diving straight into the incredibly complex systemic cascade of decompensated cirrhosis. We're going to map out exactly how a failing liver triggers this massive domino effect across the entire body, and honestly, more importantly, how modern medicine is fighting back.
To set the stakes right out of the gate, just look at the sheer drop-off between these two timeframes. A compensated liver, one that's damaged but still somehow keeping up with the body's demands, can actually hide that damage for over a decade. We're talking a median survival rate of about 12 years. But the very second decompensation hits, that median survival absolutely plummets to just 2 years. It is a sudden, drastic shift from a localized liver issue to full-blown multi-organ system failure.
So, what exactly knocks over that first domino? Well, the inciting push is clinically significant portal hypertension, or CSPH. As scarring builds up in the liver, blood flow faces some intense resistance. And once the pressure in the portal vein reaches a critical threshold of 10 millimeters of mercury, bam, the body's compensatory mechanisms are completely overwhelmed. This high pressure triggers a massive release of vasodilators, primarily nitric oxide, right in the gut's blood vessels, the splanchnic bed. Because these vessels dilate so drastically, the effective blood volume just drops. The body is essentially fooled into thinking it's bleeding to death. To survive this perceived blood loss, it chronically activates emergency hormone and nerve alarms, the neurohumoral system, which then clamp down on the kidneys to desperately retain sodium and water.
Moving into Section 1, ascites and systemic infections. This is our first major set of falling dominoes, fluid overload and the leaky gut.
When all that fluid massively builds up in the abdomen, a condition we know as ascites, it marks a huge prognostic turning point. The stepwise approach to uncomplicated ascites starts with restricting dietary sodium to under 2 grams a day. Then, we use a very specific dual diuretic therapy, an aldosterone antagonist like spironolactone paired with a loop diuretic like furosemide. And we dose this strictly in a 100 mg to 40 mg ratio. This exact balance is absolutely crucial to prevent the patient's potassium levels from swinging dangerously out of control. We also do a diagnostic paracentesis, drawing fluid with a needle just to make sure it isn't infected.
Now, what's really interesting here is how the treatment drastically shifts if the ascites becomes refractory, meaning it just doesn't respond to those diuretics anymore. At that point, we have to physically drain the fluid through serial large volume paracentesis. But there's a major catch. If we drain more than 5 liters, we dramatically alter the body's internal pressures. So we have to immediately replace that volume with intravenous albumin, about 6 to 8 grams for every liter removed. If we don't do that, the patient faces post-paracentesis circulatory collapse and sudden kidney failure, which is exactly what we're trying to avoid.
But fluid isn't the only risk down there. Because of that portal hypertension, the gut actually becomes leaky, which allows live bacteria to cross over into the bloodstream and infect the ascites fluid. This is a deadly condition called spontaneous bacterial peritonitis. But look at this survival shift. If we aggressively treat this by adding IV albumin on days 1 and 3 alongside a cephalosporin antibiotic, we slash the mortality rate from 29% all the way down to just 10%. Albumin doesn't just expand volume here. It literally protects the kidneys during the infection.
Section 2, bleeding and brain toxins. As the pressure builds, we encounter physical ruptures and toxic buildups.
Let's talk about the risk of internal bleeding. This high pressure causes veins in the esophagus to balloon into varices, which can violently rupture. We used to have to put a camera down everyone's throat to check for these, but the recent Baveno 7 guidelines brilliantly outline a non-invasive rule of 5 using liver stiffness measurements via elastography, which is essentially just a specialized ultrasound. A stiffness under 10 kilopascals rules out high-risk varices, saving patients from unnecessary endoscopies. Once we hit 20 or 25, though, we know we're dealing with extreme pressure and need to intervene, usually with beta blockers like carvedilol to bring that pressure down.
Beyond the physical pressure, we also have a massive chemical problem on our hands: hepatic encephalopathy. See, a healthy liver takes toxic ammonia, which is produced by gut bacteria, and turns it into harmless urea. But a cirrhotic liver lets that ammonia sneak right past, dumping it straight into the systemic blood. When that ammonia hits the brain cells called astrocytes absorb it and convert it into glutamine. And glutamine acts like a sponge, pulling water into the cells. This causes toxic brain swelling, severe confusion, and eventually coma.
So how exactly do we clear this brain fog? Well, we attack the gut. We use a synthetic sugar called lactulose, which changes the acidity of the intestines and literally traps the ammonia by converting it into non-diffusible ammonium. This forces the body to just excrete it in the stool. We often pair this with rifaximin, which is a targeted antibiotic that wipes out the specific gut bacteria responsible for producing the ammonia in the first place.
All right, Section 3, the kidney connection. Now let's look at how liver failure indirectly starves the kidneys, a condition known as hepatorenal syndrome, or HRS-AKI.
Remember earlier when I said the body is fooled into thinking it's bleeding, so it clamps down on the kidneys? Well, that extreme vasoconstriction eventually shuts the kidneys down completely, but we do have a powerful counterattack. The landmark Phase 3 CONFIRM trial proved that using a potent splanchnic vasoconstrictor called terlipressin, combined with albumin, significantly doubled the verified reversal rate of HRS compared to a placebo. It forces those dilated gut vessels to constrict, pushing blood back into the central circulation and essentially waking up those starved kidneys.
However, the crucial point here is that this powerful drug comes with a severe trade-off, an FDA-boxed warning for respiratory failure. While terlipressin forces blood out of the gut to save the kidneys, that fluid can back up into the lungs, causing hypoxia. It proves yet again that treating one organ in decompensated cirrhosis can severely jeopardize another. It's just a constant, delicate balancing act.
Moving to Section 4, the transplant waiting list. When the dominoes have all fallen, the race against time on the transplant list begins. But first, we absolutely must fight the body's starvation mode.
Now, you might think someone with liver failure should restrict their diet, right? Actually, it's the exact opposite. A cirrhotic liver can't store glycogen for energy. So after just a few hours of fasting, the body thinks it's starving and starts eating its own skeletal muscle to survive, leading to severe frailty. To stop this, patients need to eat 1.2 to 1.5 grams of protein per kilogram of body weight spread across 4 to 5 small meals. And here is a truly surprising absolute game changer: a late-night, high-protein, high-carbohydrate snack. To a layperson, it sounds like a diet cheat. But here, this single intervention bridges the longest fasting period of the day while they sleep, drastically preventing muscle breakdown.
So, why does preserving all that muscle matter so much? Because this frailty actually exposed a fatal flaw in the old MELD-NAS transplant scoring system. The MELD score basically dictates your place in line for a transplant, and it heavily relied on blood creatinine levels to measure kidney function. But creatinine is a byproduct of muscle mass. Because women naturally have less muscle mass than men on average and lose it rapidly in cirrhosis, their creatinine levels looked artificially low. The scoring system thought their kidneys were totally fine, which unintentionally kept female candidates artificially low on the list, leading to systematic undertransplantation.
To fix this dangerous bias, the new MELD 3.0 score explicitly adds 1.33 points to female candidates. It also caps the maximum creatinine value at 3.0 to prevent severe intrinsic kidney disease from artificially outweighing liver disease, and it adds serum albumin as a marker of overall systemic sickness. This entire restructuring ensures a much fairer, much more accurate allocation of life-saving organs.
Finally, Section 5, the hope of recompensation. Let's explore a massive paradigm shift in modern hepatology that offers genuine, profound hope. For decades, we thought decompensation was a one-way street. Once you fell off the cliff, you were just managing the descent. But Baveno 7 introduced this incredible concept of hepatic recompensation. It turns out, if you can completely cure the underlying root cause, like curing hepatitis C with modern antivirals or maintaining strict, long-term alcohol abstinence, the liver can actually heal itself. If a patient can go 12 months without any ascites or encephalopathy and their MELD score drops below 10, they have functionally reversed their decompensation. The liver's ability to regenerate is truly staggering.
This incredible regenerative resilience leaves us with a pretty provocative thought to end on. We used to view decompensated cirrhosis as an irreversible terminal decline. Now we know that by targeting the root cause, we can literally step back from the brink. It begs the question: if a failing, heavily scarred liver can remodel and heal itself, what other seemingly impossible medical boundaries are we destined to break next? Thank you for joining me for this explainer, and keep questioning what we think is impossible.